contains the posterior tibialis, which is an inverter of a foot. There's a little tug of war that goes on there that may have some implications in the next thing that may or may not impact psoas function. That thing is foot and ankle mechanics. I will say right now, it's relatively questionable as an idea. I've seen very little evidence outside of a few articles from applied kinesiologists, but let's take a look at the arguments. Z-Health people believe, or some of the Z-Health people believe, it to be the navicular bone position somehow impacts the orthokinetic reflex and would shut down the psoas. I haven't seen a whole lot of evidence for it, but maybe it exists. Also, as I mentioned earlier, that tug of war between the lateral line and the deep front line, the tibialis posterior, may have some effect on the psoas. Fredrickson and his colleagues demonstrated that distal injuries to the body, be it in the hand or the foot or the ankle, produce more weakness to the entire limb than more proximal injuries. So maybe an injury to the foot or ankle can indeed inhibit psoas function in some way, shape, form, or fashion. And also is a little muddy. The applied kinesiologist, as I mentioned, there's a book, Complementary Sports Medicine, that says the talus being out of alignment, quote unquote, is the reason for psoas dysfunction. As I mentioned earlier, the Z-Health people say navicular. Which one is it? I don't really know. Might not be any of them at all. However, I've come to the conclusion that I'm probably going to work on ankle mobility with most of my athletes anyway. So if the psoas function improves by improving ankle range of motion and mobility, then that's just another perk. So how do you assess? What are we looking for? Like most things, typically I start out with a visual assessment. Where are the toes pointing? Is there a divot posterior to the greater trochanter that could be suggestive of overactivity of the deep rotators of the hip and that butt gripping concept? I'll also check for mobility or length. Some things I'll use Yonda's straight leg crunch, the modified Thomas test, Craig's test, Ober's test. Also to check function, activity, to see maybe if it needs some activation work. We'll use a seated hip flexion test, also the 90-degree hip flexion iso test in standing, and we'll evaluate ankle mobility. It doesn't mean that you have to use all of these, but they're just some tools to have in your toolbox in case. So first of all, with the general visual assessment, where are the toes pointing? Are they pointing out more or less? Are they duck-toed? Also, is there a rotational element visible from the rear? We're going to see maybe is one side of that psoas hypertonic? Maybe not. Is the QL elevating the pelvis on one side? There's a possibility. Maybe if there's an anterior pelvic tilt, that there's some psoas hyperactivity going on. These are things that you can just see with your eye that you're going to have to correlate later with a functional assessment. Also, to note, and in this photo, to see if there is a divot just posterior to the greater trochanter of the femur. For some of the mobility, the movement tests can use Yonda's straight leg crunch. It's suggestive of the length and maybe a little bit of the activity of the psoas. So a negative result, the shoulder blades clear the table without the feet coming off. That means that the psoas is probably not hypertonic or short. Okay, positive result being the feet rise before the shoulder blades can clear the floor. This, of course, being a good test, a negative result for psoas shortness, and this one here being a positive test for psoas shortness. Also, the modified Thomas test, it gets a pretty bad rap for reliability as the length of the or for the length of the psoas and other hip flexors. However, it's still a pretty reasonable one in my book. It can suggest the degree of impairment you found with the Yanda's sit-up. You can also note the hypertonicity of other hip flexors. So if the knee is almost straight, you can say, well, the rectus femoris is probably pretty toned here. If the knee doesn't fall below the hip, let's say the psoas, maybe a combination of all of them. If there's an internal rotation component going on, maybe the TFL has too much activity. All kinds of different stuff you can look at there if you know your functional anatomy. Craig's test is not necessarily one that's going to indicate any psoas dysfunction. However, it's something that can help determine if your client's going to be able to internally rotate the hip well enough to actually get enough flexion. It's important to remember that with hip flexion as it's occurring, a degree of internal rotation at that hip is essential. So what you do is you palpate the most lateral portion of the greater trochanter and you move them into internal rotation and you see where that trochanter becomes most prominent. From there you measure with a goniometer the stationary bar of the goniometer perpendicular with the table, other side there. Between 8 and 15 degrees is determined normal. Below that, the femoral head, femoral neck is in retroversion, and above would be in anteversion. Also, Ober's test, traditionally it's used to monitor length of the IT band, the TFL. What we use it for here in looking at psoas function or just hip flexor function in general is you take your patient back and you allow their leg to drop down and see if there's a hip flexion bias at all. So a positive test for shortness of the hip flexors obviously is that flexion bias. A negative result is the leg drops straight down into the adducted position. From here we're going to get into a little bit more of the function of the psoas to see how well it's working. So the seated hip flexion, you have a client on a table, feet off the ground. You have them lift up one knee. It's best to probably observe this from behind because this way you can observe to see if there's any hip hiking, any side shifting, any leaning back. Obviously have your client do this from as many positions as you think is necessary. As well, I think it's important to assess for activity of the superficial muscles, so to see if you're trying to get any help from a posterior tilt of that pelvis, anything of that nature. A pass would be no shifts, there's very little superficial muscle activity. There's a fail, well, there's heavy activation of the superficial muscles, there's some leaning back, there's some side shifting, some hip hiking, anything of that nature. Says, well, maybe we need to work on that psoas a little bit. Also, the hip flexion ISO, as you can see here on the right, I've stolen this picture from Mike Boyle. He's actually the guy who I got the test from initially. If you remember back, I was saying that the psoas is a muscle that is capable of holding the hip above 90 degrees of flexion, and it's the only one. So what you do is you position the hip above 90 degrees of flexion on a box and have the client lift his foot off the box and hold for as long as possible. Again, side shifting, hip hiking, leaning back is not desirable. Typically, we're using 15 seconds as our criteria. However, I'm sure you'll come up with your own number based on your experiences. And lastly, we always check ankle function, not necessarily due to its direct correlation to the psoas, but maybe its potential correlation, and also it's always good to know if you need to work on people's ankle mobility. So, also, some static position we look for ankle function. Are the toes turned out? Are the feet pronated? We watch them in gait. So, are they walking duck-toed? Again, do they pronate through to get that extra range of motion? Our test is the wall drill, as you can see here. So, you'll have somebody position their body with their foot about 1 inch from the wall. You'll have them drive their knee over their second toe. If they can touch the wall, you move back another inch. If you can get to about 3 to 4 inches without pronating,